There we go. We'll try it again. Colleagues, the meeting has resumed. I'd like to welcome our witnesses for the second panel, beginning with Dr. Sonyu Gang, Chief of the Sunnybrook Health Sciences Center, Department of Psychiatry, followed by Dr. Eleanor Gittins from the Canadian Psychological Association. Dr. Sam Mikhail, psychologist, is also present via video conference. Thank you all for joining us. We're going to begin, each will have 5 minutes, and we'll begin with Dr. Gain. The floor is yours.
Thank you very much. My name is Sonu Gand. I'm a full professor, psychiatrist, and governor at University of Toronto, chief of psychiatry at Sunnybrook, and a past president of the Canadian and Ontario Psychiatric Associations. My expertise is psycho-oncology, working with cancer patients and their families. I am not a conscientious objector and was physician chair of my prior hospital's MAID team. My roles inform my expertise, but I'm presenting as an individual, not for any group. Thank you for the chance to speak. My testimony is not easy to say, nor easy to hear, but it's necessary to be said. Those seeking expansion claim not providing MAID for sole mental illness is discrimination, echoing claims by Senator Couture. The opposite is true for 3 reasons. MAID is for irremediable medical conditions, ones that we can predict won't improve. Worldwide evidence shows we cannot predict irremediability in cases of mental illness, meaning the primary safeguard underpinning MAID is already bypassed, with evidence showing such predictions are wrong over half the time. Scientific evidence shows we cannot distinguish suicidality caused by mental illness from motivations leading to psychiatric MAID requests, with overlapping characteristics suggesting there may be no distinction to make. Finally, those with mental illness have higher rates of psychosocial suffering. This all means MAID assessors will be wrong over half the time when predicting irremediability, will wrongly believe they are filtering out suicidality, and will instead provide death to marginalized suicidal Canadians who could have improved. That is the ultimate discrimination. Those setting policy have reassured us we're ready to provide MAID for mental illness. I've reviewed our legislation, the Health Canada Practice Standard, and the CAMAP training for MAID for mental illness. As someone who supports MAID in general, I assure you we are not ready. Regarding irremediability, Dr. Gupta acknowledged in her 2020 AMPQ report that it's possible a person who has recourse to MAID could have regained the desire to live, saying this should be an ethical decision each time. Her 2022 expert panel refused to recommend any additional legislative safeguards, despite Canada lacking legislated requirements for due care and no reasonable alternatives before MAID, unlike other countries. Professor Downey claimed irremediability is a legal term rather than a clinical concept. Try those mental gymnastics on your constituents. Convince them it was okay their loved ones with mental illness got MAID, not because of a clinical assessment based in medicine or science, but on the ethics of the particular assessor. Regarding suicidality, Senator Couture and Dr. Green claim suicidal people won't get psychiatric euthanasia, and Dr. Gupta claims assessors can identify and separate suicidality in MAID requests because they have been doing it.
Madame la Présidente.
Madam Chairperson, if I may interrupt, could the witness please slow down a tad? He'll have the opportunity to say everything he wants to say, but when it comes to simultaneous interpretation, he's a bit quick. His remarks need to be intelligible, after all.
I'm not losing time.
No, You've paused the time, so you can continue and slow down your speech. Thank you.
Well, I can't slow down or I won't be able to finish my comments. So.
It's because of the translation.
Well, I'm sorry. I've got prepared material I'd like to finish.
Okay, so we're at 2:54, and I stopped as soon as there was an intervention.
Okay, thank you.
Okay, thank you.
So saying something false repeatedly doesn't make it true, and evidence shows they can't make the distinctions they claim. The CAMAP curriculum dangerously teaches assessors not how to distinguish suicidality from psychiatric MAID requests, but convinces them that they can, leading to remarkable statements like Dr. Gubitz saying, quote, is the patient suicidal or do they actually have a reason to wish to die, which is not the same thing. This highlights a key problem with psychiatric MAID assessments, namely the hubris of the assessor thinking they can determine irremediability and distinguish suicidality from psychiatric MAID requests when evidence shows they can do neither. Remarkably, the CAMAP suicide module neglects mentioning known risks to marginalized populations. European data show a gender gap of twice as many women as men getting psychiatric euthanasia and of unresolved social suffering. Dr. Gupta stunningly dismissed this, saying this gender gap, quote, doesn't concern her since nobody really knows what it means. Signals of a gender gap are already emerging in Canada on track 2. An echo chamber has driven expansion with reassurances but no safeguards. It's reassurance theater. In recent weeks, I've worked with over 200 colleagues debunking a slew of disinformation shaping our policies. You can see today's piece in impactethics.ca and check the new Society of Canadian Psychiatry site, sockpsych.org, for other links. CPA Chair Dr. Freeland reluctantly acknowledged she couldn't say all the readiness is there, and the lead for CAMAP's curriculum, Dr. Lee, wrote she has grave concerns about our preparedness. Dr. Gupta testified 1 to 2 patients in her practice would qualify. I can't speak to the severity of illness she sees, but Scott Kim, a researcher at NIH, estimated we'd have well over 2,000 patients yearly getting psychiatric euthanasia. This expansion is not so much a slippery slope as a runaway train. Like the Lac Mégantic disaster, government has plenty of signs we should not be proceeding. You can choose to go ahead, but you can't pretend you weren't warned. We are not ready. You'll have to decide whether you stick with an arbitrary deadline or whether you responsibly stop this train. Thank you.
Thank you, Dr. Gang. Dr. Guetin, you have 5 minutes.
Thank you, Madam Chair and members of the Special Committee for the invitation to the Canadian Psychological Association to appear before you this evening. My name is Dr. Eleanor Gittins, and I am the sitting president of the CPA. I'm a professor and a program coordinator in the Addictions Treatment and Prevention Program at Georgian College. I'm joined by Dr. Sam McHale, who is a CPA past president and adjunct clinical faculty member at the University of Waterloo. The CPA is the National Association for Practice, Science, and Education of Psychology. There are approximately 19,000 registered psychologists in Canada. The CPA recognizes the significant work of the Special Joint Committee on such a sensitive and delicate matter as medical assistance in dying. In considering the pending application of MAID, where a medical disorder is the sole underlying medical condition, the CPA made a series of recommendations in response to the report of the expert panel on MAID and mental disorders released in May 2022 and was in advance of the Special Joint Committee's June 2022 interim report. These recommendations have been shared with the Ministers of Mental Health and Addictions, Health and Justice, as well as the committee. The CPA also created a task force on end of life and produced 2 reports, the first in 2018, that discussed various issues related to MAID, such as decisional capacity, advanced directives, and the role of psychologists, and the other in 2020, which outlined practice guidelines for psychologists involved in end-of-life decisions. In the interest of time, we will not cover all of the recommendations in our report, but would like to highlight the following. Currently, the experts panel report recommends that an independent assessor should be involved with MAID, where a mental disorder is the sole underlying medical condition, and it names psychiatrists as the experts. We fully agree that these cases will require an assessment independent of the treating team or provider. However, we strongly recommend that psychologists be named as additional expert assessors in these cases. Psychologists are the country's largest group of regulated mental health care providers able to assess, diagnose, and treat mental disorders. We offer expertise relevant to MAID decisions while expanding the qualified assessor pool. Psychologists' expertise in the administration and interpretation of objective measurements have established validity, reliability, and embedded indices aimed at identifying inconsistent responding, phased responding, symptom exaggeration, and suicide ideation or intent is vital to the assessment of individuals requesting MAID where mental disorder is the sole underlying medical condition. In developing the newly established curriculum for MAID assessors, the CPA has not been given the opportunity to review and/or provide input. Given psychology's expertise in the development, administration, and interpretation of psychometric measures for the purposes of complex assessments, we see this as a significant oversight. When it comes to a decision regarding end of life, and when that decision may be impacted by even the slightest possibility of compromised decision-making due to impaired cognitive functioning, the highest standard of care must be taken in conducting objective assessments in order to guide the final determination of eligibility. Psychologists as specialists in assessment and diagnosis of cognitive functioning are uniquely positioned to ensure this standard of care. Given this training, and because psychologists have extensive training in research methods, they should be equally involved in MAID research questions, both for end-of-life care issues and where a mental disorder is the sole underlying medical condition. Here, we refer to Recommendation 19, which states that the federal government should fund both targeted and investor-initiated periodic research on questions related to the practice of MAID. We would also like to address the expert panel's recommendation number 2 that MAID assessors should establish incurability with reference to treatment attempts made to the point, outcomes of those treatments, and severity and duration of illness, disease, or disability.
Thank you, Dr. Gittens. Thank you.
Thank you. We'll go into the first round of questions, and we begin with Mr. Cooper for 5 minutes.
Thank you very much, Madam Co-Chair. I'm going to direct my questions to Dr. Gain. You mentioned that you thought CAMAP training on MAID and mental illness was not adequate to ensure readiness. Can you elaborate on that?
I'd be happy to, and I'll reiterate, I think it's wholly inadequate. I'll be stronger in saying that. I think we could have gotten a better use out of our $3.3 million that went for that. But, pejorative comments aside, it's something where when I look at that, I'm looking to see, does this help the assessors in any either evidenced or reasonable way tease apart things like irremediability, which, as I said, it's not a question of whether a situation is irremediable, it's whether we can predict it to be. That's the whole point. We're making predictions in advance of giving someone death when they're not dying. There's nothing in there that helps us predict irremediability. And the other one is suicidality. And this one actually, I have to say, shocked me, literally shocked me. I'm looking at it right now, but the module on suicidality, it consists of 10 pages, of which 5 slides have content and a 4.5-minute audio clip. And there's nothing in there about, for example, the 2-to-1 female-to-male ratio of psychiatric euthanasia in the places that get it. There's nothing in there about suicidal risk of marginalized populations. And they simply make comments like this: managing suicidality is something most clinicians learned at some point in their training. The general principles of managing suicidality apply in the MAID context as well, whether person is requesting under track 1 or 2. I don't even know what that means. It doesn't provide guidance. Well, but it does dangerously tell people that they think they can separate suicidality from a psychiatric MAID request, and no evidence supports that.
Well, and on the issue of irremediability and suicidality, Dr. Gupta, in the case of irremediability, says that psychiatrists are equipped to make judgments on a so-called case-by-case basis, exercising their clinical judgment. And with respect to suicidality, Dr. Gupta has asserted that there is no issue in terms of determining that of a rational request from one motivated by suicidal ideation, because supposedly psychiatrists do this all the time. I'd be interested in your comments and response.
I've heard that echoed by many people, actually, and it is simply not true. Our suicide assessments that we're trained to provide through residency are not about distinguishing suicidality from whether somebody wants to die through MAID. It's a completely different thing. The CAMAP guidance, they focus very heavily on whether it's impulsive or not, completely bypassing and missing the fact that many suicides are actually planned out, well thought out over a period of time. There's nothing in there that helps us tease those apart. Furthermore, the evidence from the European countries shows overlapping characteristics between those who actually attempt suicide, most of whom do not try again and do not take their lives by suicide, and they benefit from suicide prevention, but overlapping characteristics between those people and the people who seek and get psychiatric euthanasia. So the obvious concern is, are we converting transient suicidality, which may be fixed for a relatively long period of time but still abates with suicide prevention? Are we converting that to a 100% lethality through MAID? And that's why the 2-to-1 ratio of women to men who get psychiatric euthanasia should terrify any psychiatrist, because that 2-to-1 ratio is exactly the same as the 2-to-1 ratio of women to men who attempt suicide when mentally ill, as I said, most of whom do not die by suicide and do not try again. And we think that reflects gender-based marginalization. How can we be ignoring that as a country and just saying we're ready to march ahead in March 2024?
In her testimony, Dr. Gupta claimed, quote, "Some of the voices that are saying we are not ready have contributed nothing to becoming ready," end of quote, and that, quote, "those voices have not been involved even when opportunities have clearly been presented to them," end of quote. Do you agree that that's a fair characterization?
I don't agree it's a fair characterization. I'm actually shocked that she said that. She should know better than most that many people have wanted to be involved and have not had the opportunity to be. And that includes for many things that I can give further details on, but I know that the time in your question is limited. But I do not agree with that.
Thank you very much. Next, we will have Ms. Koudrakis for 5 minutes.
Thank you, Madam Co-Chair, and thank you to our witnesses for being here with us tonight. My questions will be directed to Dr. Gittins and Dr. Mikhail. And we've heard this question time and time again, and other witnesses have answered to it. So I will ask the same one to see how your view differs, if it does in fact. Do you think that the health system is ready for an expansion of MAID eligibility on March 17, 2024 for individuals whose sole underlying medical condition is a mental disorder?
I think the issue of readiness involves looking at several components. First of all, legislation. Is it in place? Yes, it is. Second of all, are regulations in place? And I would argue that regulations are incomplete because they've not been looked at by the broader mental health community. They've been looked at, as was indicated earlier, the Federation of Medical Regulatory Authorities. That's a narrow group, I think, that's involved in mental health care. So there's more work to be done there. A third element in terms of determining readiness is having some indication of what will the demand be. And we have no idea what the demand will be. Obviously, we need to measure demand against available resources in terms of individuals that are prepared to do these assessments. And we don't know that ratio. So I think that we have a lot of gaps in terms of making that determination.
And what, in your view, then needs to be accomplished to ensure readiness of the health system for MAID and mental illness? If you were to give this committee one recommendation to take back and say, this, these are the points that I think, as an organization or as an individual, that would ensure readiness.
I think one of the points that Dr. Gittins made in her opening remarks is it's really, really critical to look at a thorough and expansive way of assessing someone's request for MAID, whether it's someone with a mental disorder or another track 2 request. And to do that simply based on interview, I think is short-sighted and inadequate. Interviews, conversations with patients are prone to bias, and we need more objective indices of assessing someone's mental state and putting that mental state within, or the request rather, within the context of that mental state. There's a very, very extensive body of research that goes back to the 1950s and has continued since, that makes it very clear that actuarial prediction is far superior to clinical prediction. And so I think that's at the very, very least, one of the things that's necessary in order for us to move to a state of readiness. Look at how these assessments are done and whether that actually meets the standard.
And do you feel, Dr. Mikhail, that the resources that are there in place right now are adequate enough to help people to assess, our healthcare providers? Do they have the resources, the adequate training, the adequate tools that they would need to assess whether someone should qualify for MAID or not when faced with a mental disorder?
My view would be no, I don't think we're quite there yet. I think, again, if we are to take the issue of assessment seriously and expand it beyond simply having a conversation or a clinical interview with the individual, record reviews, and so on and so forth, and then include more objective measures, I don't think that training is there, at least not as it currently stands.
Do you think
40 seconds.
Thank you. Do you think we will get there as a country, given what we're seeing so far? Do you think we're ever going to get to the place where we will reach consensus?
No, I don't think there'll ever be consensus. I think there'll always be people that, and a segment of the healthcare community as well as society that doesn't feel that this is something that should occur, and a segment, obviously, that supports it. I think one of the issues around mental disorders is mental disorders, we're saying as the sole underlying medical condition. Not all mental disorders are medical conditions. And I think we've kind of cornered ourselves by using that terminology.
Thank you very much. Next, we'll move to Monsieur Thériault for 5 minutes.
Oui.
Thank you very much, Madam Co-Chair. Dr. Gaint, you've been practicing psychiatry for how many years, sir?
Publicly, maybe 25, something like that,
Okay.
20, 25.
Dans
I'm not very good in the math
toute
right
votre pratique,
Over the course of your clinical practice, have you met patients whose state was irremediable?
So I've met patients in the course of my practice who have not gotten better, and I've met more who I never thought would get better and did.
on espère bien.
Well, we indeed hope so, because psychiatry should be able to provide something other than just palliative care and infinitum for those who suffer. Wouldn't you agree?
Absolutely. It's about trying to help somebody re-engage meaning and purpose of life. We are able to do that. The point I was making in my preceding comments is that I could not have predicted which of those people would or would not get better. The vast majority did get better. And if I had thought they wouldn't...
I understood that, sir. I did understand that. And it's curious in a sense, because mental disorders are of a particular category. Cancer is far more straightforward in phase 4 and in the terminal phase. We understand that. And now in the expert panel's report, because of this difficulty, I thought that there were a number of guidelines, i.e., that the disorder should be a chronic one over a specific protracted time frame, and that that individual may have suicidal ideation, but we know that suicidal ideation is reversible, and that over the course of many years and thanks to many treatments that are supposed to improve one's condition, I end up with a patient, and I know that there are a small subset of patients that have tried everything at their disposal and who have been constant right through till the end point where they decide that their life is devoid of meaning, as the Collège des Médecins described, sense of meaning to one's life. Don't you think that the expert panel's report contains a number of guidelines such that we could at least hope to have a sustainable and safe practice that would help those individuals with mental disorders and not simply discriminate against them on the basis that they are in a category that is medically difficult to care for?
It's not about being medically difficult to care for. It's about being impossible to properly predict that they won't get better. And that means that you would be providing death under false pretenses. That's my problem with this. And in terms of your question, I'll answer it with two things about the people who don't get better. The people who have those lengths of trials and who have suffered that long, I will remind you that we have no legislated safeguard that actually requires that. Dr. Gupta's expert panel explicitly said that they are not recommending any additional legislative safeguards. And that is remarkable, because anything else just becomes suggestions and reassurances. And even Dr. Lee, the scientific lead for CAMAPS.
I'm sorry to cut you off, but in the expert panel's report, recommendation 10, which does not apply to any other cases of MAID, that there is a second independent psychiatrist who specialises in mental disorders who would make this assessment possible. There's also recommendation 16 related to prospective oversight. What do you think of prospective oversight that is not to be found in any other practice from coast to coast to coast, or in Canada or Quebec?
The things that you're quoting, firstly, I'll point out that's not in the health practice standard. They actually removed the suggestion that there be a specialist involved. So that is no longer there. And Dr. Gupta was one of the 6 people who also wrote that. And in the same expert panel report, they say literally, we are unable to provide guidance on the length, number, or types of treatments required before providing MAID for psychiatric illness. That's not any guidance.
But it's not because it's not in the report that we can't proceed in that manner or propose it. So would you agree that recommendation 10 should be put back in place?
The time has expired. We're over by several seconds. Did you want to just a quick yes or no?
Well, it would have been good for the committee to hear the answer, nevertheless. Given that there is lag with interpretation, I would indeed like a response to that question. I know that it's not normal per se, but why not put back in place recommendation 10?
No, it would not provide the safeguard that you're thinking it would.
Okay, merci. We have Mr. McGregor next for 5 minutes.